Greetings and welcome all. Thank you for joining us for our exciting discussion today, Sustainable Financing 2030, Accelerating Integrated and Country-Owned HIV Responses over the next 5 years. My name is Dr. Kimberly Green, and I'm the Global Director for Primary Healthcare at PATH, and I'll be co-moderating today's session with Dr. Laurel Hatt, who's the Senior Program Director at Results for Development. And who brings extensive sustainable financing expertise. So delighted to have her as my co-moderator today. Before we get started, I wanted to share a few housekeeping items. So next slide. As you join the call, feel free to introduce yourself in the chat box. This meeting, of course, is being recorded, and the recording and materials will be shared after the webinar. We very much welcome questions throughout the webinar at any time, so please submit your questions through the Q&A box, and we'll have a Q&A session towards the end of our webinar. But also the panelists and the speakers will be able to answer your questions as you post them as well online. Next slide. So in terms of translation, we're using Wordly AI, so go ahead and use the QR code if you need it. There'll also be information in the chat on how to access Wordly AI. Next slide. So we have a stellar and exciting lineup today, all focused on sustainable financing for HIV and as part of universal health coverage. So we'll start off first with a brief framing on why we're here, what the key issues, challenges, and opportunities are. And then we'll turn to laying the foundation, priorities for sustainable health financing. And we'll hear first from Ashneil Jain, who's the Senior Advisor for Strategy and Innovation with the Bureau of Global Health Security and Diplomacy at the State Department. So he'll be focusing on PEPFAR's work in sustaining the HIV response through aligning with country UHC financing efforts. After that, we'll hear from Justin Koonin, who's the UHC movement political panel member and also the former co-chair for UHC 2030, as well as the president for ACON. He's going to be providing framing on what the HIV response can be doing to better optimize alignment with domestic financing efforts. And then from there, we'll get into real-world experience. We're going to hear from Dr. Trizah Tracey, who's the Acting Director for Health Financing at the Ministry of Health. So she's going to be framing and sharing with us live efforts to roll out universal health coverage in Kenya and how HIV services are being integrated as part of the health benefits package. From there, we have an outstanding panel, and you'll be hearing from representatives from people living with HIV, from governments, from donors, and from advocates and other key stakeholders who are going to be talking about different angles and aspects of what's needed to ensure that HIV programming is sustained in the long run. And then we'll wrap with final words and a call to action from Laurel Hatt. Next slide. So really, as we're coming together today, the key impetus is around calling for inclusive universal health coverage in primary healthcare as part of the exciting reforms that are underway in countries of that one health plan, one integrated budget, and one M&E. Really thinking about universal health coverage as an essential tool to ensure coverage of health services and financial protection, and doing so through primary healthcare that applies the life course and through integrated people-centered care. But really wanting to make sure that HIV is not left behind. As we think about health for all, we're thinking about inclusion of those that can benefit from HIV services and those living with HIV. Next slide. And so with that comes some really important framing, some important challenges as well. So right now, about 4.5 billion people lack access to essential health services. And of that, nearly 2 billion lack access to health services due to financial barriers, with around 1 million people who fall into poverty each year because of health-related expenses. And so I think all of us know that country health budgets are constrained by inflation, by debt, by competing priorities, and of course, by the investments that were made for COVID and by the impacts of climate change. However, at the same time, we know that investing in universal health coverage leads to strong social and economic benefits, and that for every $1 invested in UHC, there's a $9 return on investment, which is a very good deal and contributes to strengthening economies. And so as we look at 60 countries that are in different stages of adopting UHC, around 38 have included financing for ART, and around 21 for PrEP in different stages and in different ways. But this is very important progress. Next slide. So we know, go back one slide, please. We know that with, overall HIV financing globally, domestic financing makes up the majority of HIV investments, but that's declined since 2017. And of course, there's also significant variability from low-income countries to upper-middle-income countries, and really significant difference between the allocation of domestic financing for health spending overall versus for HIV, and then as well compared to those allocations for HIV prevention. So still more work needs to be done. Next slide. But with the challenges, there are always opportunities, and there are many of them right now. So number one, with the Lusaka agenda, and you'll hear more about that from Justin Koonin, there's increased commitment among countries to really align, and with donors as well, to align against those one health, one budget, one M&E plans through UHC and primary healthcare. Also, there's very strong donor alignment through country-led HIV sustainability plans, and you'll hear more about that in just a moment from Ashneil Jain. With increased momentum as well around primary healthcare, which is so exciting, and as well investing in integrated community health workforce, and also embracing integration of services and systems for greater outcome and efficiencies, lots of exciting opportunities. As well as for HIV prevention, you'll know, of course, that there are some very exciting new HIV prevention tools, which can also enable greater coverage and faster reductions in new HIV infections, as well as looking at greater efficiencies for those inputs that are essential for health programs, HIV medicines and diagnostics, and looking at how to further reduce costs. And then finally, and we'll hear more about this on the panel, discussion, but really enhancing the role of the private sector, social enterprises, impact investors, and others that can extend financing coverage. So next slide. With that, it's my honor to turn to Ashneil Jain, who's going to be framing PEPFAR's response towards sustainable financing. So over to you, Ashneil.
Yeah, thank you, Kim, and good morning, good afternoon, good evening, everyone. I just want to spend the next few minutes talking a little bit about PEPFAR's priorities over the next 5 years and how it aligns with the discussion we're having today about sustainably financing the HIV response and how it intersects with the broader public health agenda that most of our partner countries have. So if we can go to the next slide, I think the first place I want to start, and if you can go one more slide, is really around where we are in the response and what's needed to keep the response under control in a sustainable way. And I'm first highlighting the fact that we've made tremendous progress. The most recent results published at World AIDS Day by PEPFAR: 26 million lives saved over 21 years, 7.8 million babies born free of HIV. But we can't confuse that tremendous progress that PEPFAR, other partners with our country government counterparts and civil society and communities have had with victory. Because the task ahead of us is, well, maybe not the extreme emergency it was 21 years ago when PEPFAR was founded, a uniquely challenging task of keeping millions and millions, 20.6 million people in PEPFAR-supported countries on ART treatment and virally suppressed, finding the remaining 6 million people living with HIV who are not on treatment, bringing down the 1.3 million global HIV infections we have every year, which, by the way, we're far off track from reaching our 2030 goals on that front. The major inequities that still remain in the HIV response for adolescent girls and young women, children, the 5 key population groups, which continue to be a challenge. And then the fact that in PEPFAR-supported countries, roughly 60% of the HIV-specific funding is being provided by donors. And if you adjust that by taking out South Africa, that number is even higher. And so we really have a fundamental challenge ahead of us in terms of how we move forward with the program. And as PEPFAR, we are working on laying out a very specific agenda starting in our next planning cycle, where we talk about how PEPFAR needs to make a shift intentionally away from its history of being an emergency response program and moving towards a program that is really focused on sustaining the response. So if we move to the next slide, that overall shift of moving from an emergency response to a sustained response, PEPFAR is really anchoring that into a single future state vision for the sustainability of the HIV response. And I'm just going to read it out here because this is really going to anchor our work over the next 5+ years. The large majority of HIV prevention, care, and treatment programs will be led and delivered by government or delivered by other domestic entities with community engagement and government accountability. And this is an attempt to really define how the HIV response needs to evolve. And we expect that in a cohort of PEPFAR-supported countries, not all PEPFAR-supported countries, but a cohort of them, we will have achieved this goal by 2030. And we expect that once a country has achieved this goal, there's going to be significantly greater financing of the HIV response by that country, either through domestic government, combination of private sector sources, and that the services themselves, the HIV services themselves, the essential services, will be delivered through national and community systems. And I think if we are successful, you will have seen PEPFAR's support in those countries really evolve to be much more targeted, focused on capacity building, innovation, protecting the most vulnerable populations that are still left behind, but really a fundamental transformation in the way PEPFAR does its work to support country programs. And I'll just acknowledge that achieving this goal is no small feat. I think it's going to be an exceptionally challenging effort ahead of us. But if we go to the next slide, I want to lay out what will it mean to unpack this goal and sort of achieve it in a particular country and how that get translated across the countries that PEPFAR supports. So the first thing you need to do is to keep the epidemic under control. And that really means reaching the 95 levels and maintaining a population level viral load suppression rate of about 90% across the population to keep the epidemic fully under control. It also means being able to bring down the rate of new infections. As mentioned earlier, we're still off track on that goal. And so we really have to bend the curve on new infections. And lastly, we have to reduce the inequities that are in the specific most vulnerable priority populations, key populations, children, adolescent girls, and young women. That will allow us to be able to keep the epidemic under control and ensure that our response going forward can be a financially and programmatically sustainable response, and that you don't have a large cohort of growing new infections. But complementing that is a need for a really strong foundation of national leadership. And that national leadership needs to be across 4 different dimensions: political, the programmatic dimension, partnerships, and financial. And as PEPFAR, going forward, starting in our next planning cycle, we are going to start to set very specific targets for how a country program is going to advance each of those dimensions of sustainability and a sustainable HIV response. And we'll be setting annual metrics against each of these dimensions by country to be able to see that progress, the same way that we set annual targets for particular epidemiological goals. And so if we move to the next slide, these are going to be the priorities for our next planning cycle to really advance that overall vision and those accountability targets I mentioned earlier. The first one is going to be establishing, for the first time, a country co-investment policy. And I think all you may be familiar with different co-investment policies that different donors have had in the past. We'll be designing a very specific one for PEPFAR. And these agreements will not necessarily be focused solely on financing, but they could also be very key policy and program areas that are required to advance the HIV response to a more sustainable future. So for example, in terms of integrating the HIV response into a broader public health package that's delivered across a variety of areas, geographies within a particular country, we may set a co-financing agreement that works with our partner country to integrate that HIV service component into that broader public health package that a country is developing, either for a community cotter, clinical cotter, primary healthcare cotter, et cetera. And so that will be a way to align our incentives and create kind of mutual agreement with our partner countries to really advance this agenda that will require HIV services to be folded into the broader national system. The second area, which is, I think, equally important in terms of how we advance this broader agenda, is going to be around how, as PEPFAR, we align, use, and increase our financing towards leveraging national systems to be delivering the HIV response and moving away or kind of winding down over time parallel systems that are not directly integrated into the overall national ecosystem. To do this it needs very careful thought. It will require a deep understanding about how the system itself is structured, how it's financed, and how the workers, for example, are equipped to deliver the HIV services with quality to the people who absolutely need it. We expect this to be a long-term journey, but it's one where it will be an increasing focus starting on our next planning cycle. The third thing we're acknowledging is that the current financing for the HIV service delivery infrastructure that PEPFAR, Global Fund, country governments are supporting needs to become more efficient and needs to become more simple. That will allow it to integrate itself better into national systems. It'll also allow it to be more financially sustainable. And so that will be an increasing emphasis of our program, how to streamline our program to be able to deliver the same services with quality, but do it in a more efficient manner in alignment with systems. The fourth priority will be around innovation and science. And in particular, I want to highlight here the potential that long-acting injectable agents have. I've noted a few times now the importance of bringing down the rate of new infections to ensure a sustainable response into the future. Long-acting injectables have an incredible opportunity to help advance that priority. And then lastly, a continued focus on the inequities. We know that needs dedicated attention, dedicated financing, and that has to happen in order to reach the 2030 goals. And the last note I'll end on is PEPFAR has been a partner with a lot of our partner governments in developing the first stage of their HIV sustainability roadmaps. We expect those roadmaps to really be painting a picture for how HIV services will fit into the country's broader vision for how it's going to deliver public health services and oversee those services in the long run. And so we expect to utilize those sustainability roadmaps, the first part of them that have been developed already in most countries or will be by the end of the year, and the second part of them that will come next year to inform our next set of investments so that our investments are really aligning to where countries are headed, but ensuring that the quality and reach of those HIV services are maximally utilized to be able to deliver on the 2030 epidemiologic goals that I mentioned. So I'll just close by saying we're really excited about this vision, this agenda. We're going to be describing this in a lot more detail in our upcoming COP planning guidance that's going to come out at the end of this year. And we're looking forward to all of your engagement on how we can move towards this vision together with our partner country governments, with communities, with the other partners around the table. So thank you, and back to you, Kim.
Thank you so much, Ashneil. Really appreciate this very clear and thoughtful vision towards partnering with countries in terms of HIV sustainability. And really appreciate the focus also on looking very comprehensively on political program and system partnerships, and also those financial aspects. And let's go ahead and move to the next slide, because on the alignment with financing with national systems, which you spoke to, I want to introduce Dr. Justin Koonin, who's going to be presenting on what the HIV response should be doing to ensure optimal alignment with country financing, sustainable financing efforts. So over to Dr. Justin and to the recording that we have from him.
Good morning. It's great to be here. In 2023, a process called the Future of Global Health Initiatives, led by the Wellcome Trust and co-chaired by representatives of the governments of Kenya and Norway, brought together regional and national stakeholders, including governments, international and domestic financing partners, civil society, health organizations, and academia, to reflect on how global health initiatives can be optimized to best support national health priorities and countries' progress towards universal health coverage. That process culminated in the launch of the so-called Lusaka Agenda on Universal Health Coverage Day, December 12th, last year. The agenda focuses on the work of the country-focused global health initiatives, or GHIs, principally Gavi, the Global Fund, and the Global Financing Facility, but also including CEPI, UNITAID, and FIND, and recognizes both the important contributions of these institutions over the past 2 decades, as well as changes in health needs, financing, and governance, which require a renewed vision for global health. The agenda recognizes the need for strong and resilient health systems that can adapt to emerging threats, such as climate change and conflict, while also maintaining coverage for existing health needs, including, for our purposes today, HIV. The Lusaka agenda calls for 5 key shifts to support the long-term evolution of the GHI ecosystem. Number 1, make a stronger contribution to primary healthcare, PHC, by effectively strengthening systems for health. This calls for GHIs to support integrated service delivery, aligned behind one national plan, and to invest in strengthening resilient health systems, including at community level. Number 2, play a catalytic role towards sustainable, domestically financed health services and public health functions. In low and middle income countries, just 34% of funding for HIV services is sourced domestically. However, the broader global health landscape is very different. Development assistance in aggregate accounts for only 0.3% of total global health spending, and the engine room for progress towards UHC must be domestic resource mobilization. The Lusaka agenda calls on GHIs to support movement towards increased domestic spending on health and gradual coherent transitions away from GHIs and other external support over time. Number 3, strengthen joint approaches for achieving equity in health outcomes. This is a call for GHIs to deploy integrated and targeted programming which supports and complements existing public and private providers, including community-led organizations, to reach people in the most vulnerable and marginalized situations. Number 4, achieve strategic and operational coherence. In other words, ensure that GHI structures and processes impose a minimal burden on countries and do not contribute to further fragmentation of the health system. And number 5, coordinate approaches to products, research and development, and regional manufacturing to address market and policy failures in global health, to ensure that fit-for-purpose quality health products are developed and manufactured for underserved regions. So what does all this mean for the HIV response? We know that resources, both domestic and development assistance, are constrained and face competition from multiple sources. That means health responses need to be efficient and not duplicative. We need to align behind a single national plan rather than operating in silos. One plan, one budget, one M&E framework. We also know that the barriers to an effective HIV response are not just technical and financial, they are political, and that equity and human rights are as important as dollars and cents. Many countries, to put it bluntly, do not support the right to health of some of the people in the most marginalized and vulnerable situations. As we foresee the transition of the HIV response towards domestic funding, we need to ensure that human rights are kept front and center. And lastly, and if I'd had my way, I would have included this in the Lusaka agenda, we need to ensure that we keep a focus on community-led responses and social participation. Why? Because when the people most affected are at the center of the response, the needs of those most vulnerable and marginalized are put first, and we stand a far greater chance of making good on the commitment to equity enshrined at the heart of the Sustainable Development Goals. Of course, all of these actions are much easier to dictate in words than they are to implement in practice. We're here today to discuss what actually works on the ground in countries. I'm really looking forward to hearing from the other speakers and wish you all a very happy Universal Health Coverage Day for December the 12th.
Excellent. Well, with that framing, we wanted to turn now to Dr. Trizah Tracey Jain, who is the acting head of healthcare financing at the Kenya Ministry of Health. She's going to be framing a real example of UHC scale up in process, and really importantly, how HIV services are being integrated as part of the benefits package. So over to you, Dr. Tracey.
All right, thank you very much. I hope you can hear me now.
Perfectly, thank you.
Thank you very much. I will quickly go through what I had prepared. So we could go to the next slide. In terms of financing HIV, as a part of universal health coverage, the government in Kenya has reprioritized health financing as one of the priorities towards acceleration of UHC attainment. And the other areas to go with the health financing and health products and technology, digitization and human resources for health. And all this, we're looking at building sustainable health financing so that we can be able to reduce the high out-of-pocket expenditure that we have through enhancement of the prepaid mechanisms, including implementing mandatory health insurance for the population. The other area we're looking at is a reduction in donor dependency in health through robust domestic resource mobilization, as well as looking at increasing government budgets for health to meet up the gaps. We hope that eventually we are going to be able to provide equitable access to care that is affordable and of high quality, while providing financial risk protection to our people and reduce the poverty that arises from catastrophic expenditure. Next slide, please. And towards this achievement or attainment of UHC with the prioritization of health financing, the government has enacted social health insurance legislation, primary healthcare legislation, digital health legislations, as well as facility improvement financing last year. And all this legislation focusing on the social health insurance one has enabled us to establish a body whose core mandate is to pool financial resources and strategically purchase healthcare services from healthcare providers. And looking at these reforms, the social health insurance, we have decided we've gone the way of having financing in different areas to be able to pool resources both from government as well as from contributions. And therefore, we have a primary healthcare fund, we have which is government funded, a social health insurance fund, which is contributory for the population. And additionally, there is money resources for the poor and vulnerable population from government, as well as a third fund, emergency, chronic, and critical illness fund, which looks at defraying extra costs of healthcare for services that are too costly to be taken up by the social health insurance. Next, please. This is the model that we are looking at, how we have categorized our financing mechanism. For primary healthcare fund is entirely government funded and allows the whole population to be able to access primary healthcare services without any form of payment because it's funded by the government, while the social health insurance fund allows now the population to access services from higher levels of care where it is required through a contribution of premiums. And the third fund, this one again is government funded to protect the population for emergency services, as well as costly services like cancer treatment. Next, please. In terms of implementing this initiative, we're looking at focusing mainly on making sure we have continuity of health service delivery in the country as we transition from the older model to this one. Next, please. In terms of benefits packages, we have developed benefit packages designed and costed, as well as validated through a multi-stakeholder engagement. And these benefits focuses on making sure there's an integration and continuity of care, all the way from preventive, promotive, curative, rehabilitative, and palliative health services accessible to the populations. And these benefits do include HIV services, especially HIV-related management of HIV-related opportunistic infections, HIV-related cancer services, as well as procedures for people living with HIV. And the services are all encompassing and hoping to integrate even the service delivery care for HIV so that we don't have any one being left behind. Next, please. This is how our benefits in summary they look like, where we have the primary healthcare services, and then there is now graduation to social health insurance fund, that is the secondary and tertiary services, and the emergency and chronic services. However, because of the unavailability of resources, we have decided to phase it out and implement the first bulk of services in this year, and then we load more services as we move along, as we mobilize more resources, both from government sources as well as from contributory, as more members enroll into the program. Next, please. In terms of the contributory part of the social health insurance, we've adopted a progressive mode of contribution, where all sectors, formal and informal, contribute a certain proportion of their income. And in addition to those contributions, the government takes care of the poor and vulnerable households by paying the premiums on their behalf. Next, please. In terms of strategic purchasing, we've also focused on making sure that at the purchasing of the health services, then the purchaser is able to undertake empanelment and contracting of healthcare providers. So we have accreditation just to make sure that those who have been contracted are providing integrated services of high quality. Next, please. In terms of readiness, we did recognize that other than health financing, strengthening health financing, we also looked at getting efficiency gains by focusing on digitization and making sure the facilities are digitized to provide end-to-end services, as well as making sure that all the other inputs, human resources, the medicines, all of them are available at the facility to strengthen the service delivery component. Next, please. And in the rollout, the progress that we have made so far, we are making good progress in terms of the number of populations that have been registered in about 2 months, as well as the contracting and empanelment of the providers. And we are seeing good progress, and hopefully by the end of the year, we should have reached hopefully a greater percentage of the population as far as registration and payment of premiums are concerned, and contracting of the healthcare providers who are in the country. Next, please. That is it. Thank you very much.
So with that, we would like to start first as part of this really exciting lineup of panelists. We'd like to hear first from Diana Frymus. Diana is with USAID and is the founding director of Primary Impact, and is currently serving as the Global Health Workforce Coordinator for the Bureau of Global Health, and is also the acting division chief for systems and program sustainability in the Office of HIV/AIDS. And so Diana, a core element of USAID's strategy for sustaining the HIV response has been focusing on the development of a resilient health workforce. And so it would be wonderful to hear more from you around USAID's approach to ensuring a well-supported and sustainably financed health workforce as part of the HIV response, as part of primary health care, and really ensuring the durability of high-quality HIV services as integration of HIV into primary health care continues to evolve. So over to you, Diana.
Great. Thanks so much. Kim, can you hear me?
I can. You sound
Okay,
great.
perfect. Perfect. I'm so pleased to be on this panel to discuss specifically the workforce within the context of sustainable financing for HIV. And first, I just want to acknowledge, right, the vital role that health workers have played in the HIV response and achieving the remarkable progress that we've seen worldwide. And this is further evidenced if we look at just PEPFAR's investments alone in 365,000 health workers across PEPFAR-supported countries who have been instrumental in expanding access to HIV prevention care and treatment services to a diversity of target populations. However, as we look toward the 2030 goals for HIV, we must also continue to consider the projected global shortage and the reasons behind that shortage of 10 million health workers, particularly in many of PEPFAR-supported countries. And so it's really critical that local health system institutions have the capacity to not only support, but also effectively finance and manage the workforce necessary to maintain our HIV gains and respond to those future needs. Ashneil really laid out the blueprint for PEPFAR for achieving sustainability that will really require context-specific and time-intensive solutions, working carefully to not compromise gains that have been made, but also underscoring the need to continue to work towards achieving those 95-95-95 goals. Health workers are key stakeholders as we progress towards that future state goal, where the majority of HIV prevention care and treatment programs will be led and delivered by governments and other domestic entities with strong community engagement and government accountability. And based on USAID's extensive experience through the years working with partner countries to build and strengthen and sustain their health workforces, there are several actions that we're considering that we see as key to advancing sustainability. First, we really need to align health workforce planning with the projected future needs of the health workforce for HIV services. This includes ensuring that HIV is included as part of broader service delivery packages and frameworks, particularly within the context of primary health care. And it's essential to consider the multidisciplinary nature of the workforce required for HIV services, with also having a special focus on the role of community health workers. And these workers, as many of us know, who go by many titles across countries, have been critical to the success of the HIV response. And as countries develop national community health worker programs, it's really critical to ensure that we define the specific role of these workers to play in HIV and other infectious diseases beyond just RM and CH services. We must then also identify realistic pathways to transition the cadres or the workload of workers that have been supported by PEPFAR and other donors into government-supported sustainable systems. And this requires, we have many examples that we're gathering, but very detailed review of each cadre supported and finding ways to absorb these workers or the roles that they support within country health systems without compromising gains that have been made. A great example of this is, I'm sure Dr. Tracey would be talking about efforts to advance HIV and within the government of Kenya's priorities for primary health care. But we have a great example in Kenya where USAID has been supporting rollout of the new community health promoter program and piloting in certain districts and counties how to align PEPFAR-supported lay workers within this community health promoter cadre, and really working to identify HIV functions that can be absorbed and supported by this new cadre. So it's a great example, I think, of this transition that I'm laying out, the need to think about. Second, we must really increase thoughtful investments to build countries' institutional capacity to plan, recruit, and utilize available financing for fair and productive health worker employment. And this is critical, especially, right, as I'm sure a lot of the panelists will talk more about, as many PEPFAR countries are facing tough macroeconomic conditions that limit their ability to expand the health workforce. And beyond improving efficiencies in how existing resources are used with improved public financial management, we also need to explore innovative financing options and be realistic about timeframes. This also includes consideration of public-private partnerships and other blended financing models. Key to this is also continued coordination amongst donor programs and collaboration with governments to further maximize the impact of continued investments in the health workforce. An excellent example is how this is laid out and encouraged through the Africa Health Workforce Investment Charter and healthcare worker compacts that are being developed with WHO Afro support across many countries on the continent. And lastly, health workers need safe, healthy, and supportive working environments to be effective in their roles. Yet we know across the globe, health workers are facing difficult, even dangerous working conditions, low pay, long hours, lack of protections, sometimes even experiencing harassment and violence. The WHO Health and Care Worker Compact has provided a clear framework for the global community for how to advance protection and safeguarding of health and care workers. And I also want to point out a recent legal review of countries recently published just 2 days ago, I believe, by WHO and the Georgetown O'Neill Institute, which shows how countries differ in regards to labor standards that support strong protections and safeguards, and the needs for policy intervention being presented actually on a panel later this morning with our Assistant Administrator, Atul Gawande. To ensure healthcare worker sustainability, we need to be also advancing enabling policy environments and interventions that create safer, fair, more enabling and supportive work environments. This includes stronger engagement with health workers. We need to understand their challenges and we need to understand their needs and see them as partners in advancing sustainability. A great example from USAID's work in Ghana is the recent development and endorsement of the Health Services Workers Union Together We Care Women's Charter, which puts forth interventions to help address critical issues that health workers are facing and women health workers are facing in Ghana, such as gender-based violence, workplace safety, collective power, and leadership development. Across many countries, we are seeing promising progress in these areas. Excited to hear from Grace later on the panel about the work that she is helping to support in Namibia, which provides valuable lessons on health workforce sustainability planning and institutional capacity building that could be scaled to other countries. Shared learning across countries and increased engagement with stakeholders, including health workers, is going to be key to advancing sustainability further. Thanks so much.
Thank you so much, Diana. And I'm just going to briefly say hello to everyone. I'm Laurel Hatt from Results for Development and co-moderating this panel with Kim and Path. But thanks very much, Diana, for those reminders about health workforce and the importance for a sustainability agenda. Next, I'd like to turn to Lilian Amwareko, who is the Executive Director and founding member of the International Community of Women Living with HIV and AIDS, East Africa. She is a gender, human rights, and women's rights defender and has a long history of advocating for increased sexual and reproductive health choices for women. So Lilian, a question for you. As governments work towards sustainably financing their HIV response, what considerations should country stakeholders keep in mind to ensure that health systems are financed in a way that enables all communities to have access to respectful, high-quality, integrated HIV care while preserving space for civil society to promote inclusive care?
Thank you very much, and grateful for the presentations that have been made, because they've really set the stage for us to weigh in. And I just want to probably begin by saying that sustainability and the conversation around it really requires that we are genuinely first of all, understanding what it means, but also be genuine in the conversation and the discussion. To us as communities, sometimes we strongly feel that it is seen as an easy piece of work. And also the countries are trying their level best, but to some extent, I think there's much more that needs to be put in, that needs to be understood in terms of what it means. Because, for example, in the first presentation, we really saw how much investment has been put in care and treatment. We also saw how much is remaining to be done. We also know what is at stake in terms of prevention. And therefore, when we talk about countries taking up this piece of work and role, it is not just as simple as it is on paper. It requires genuine discussions and conversations. And therefore, countries, one, must look at, are they ready? Are the countries ready in terms of the resources? Do countries have resources to, for example, keep the 40 million people that we have just seen on treatment? In the region where I come from in Africa, majority of us are on treatment that is funded and supported by PEPFAR, by Global Fund. So the question that countries must genuinely discuss, and when I talk about countries, I mean all of us, is, are we ready to take up this mantle? Is it an easy task that we are going to have people who are already on treatment and therefore continue to be grateful for the 95, 95, and 95 that most of the countries are heading towards to and others have achieved, that people are going to remain on treatment, that they are going to continue accessing affordable medicines and tools, they are going to continue having quality services, but not only quality, but of quantity, and that they are going to continue having person-centered care that we all advocate and admire. So those are some of the few things. But importantly, countries must look around issues that we are all struggling with, issues around the legal, human rights, stigma and discrimination, criminalization. So if a country agrees that they are ready to take up the mantle of caring for their citizens, the first appreciation is that they must agree that they are going to deal with human rights issues, they are going to deal with criminalization laws and policies as well as practices. Because it is not common that if you don't believe in a person, if you don't think that person must live, then you're going to take care of their health and their well-being. And therefore, countries must sit back and say, we must deal with our legal environment. We must make sure that our practices are really pro-people and human rights based, but also importantly, looking at gender considerations. And of course, we continue to talk about 95, 95, 95, and even in the presentation, it was, like clearly highlighted. But we also know that there's a 555 that we are not talking about. So countries and stakeholders must talk about what happens to the 555 that are not within the 95, 95, 95, even when we know we have not achieved the 95, 95, 95. So there has to be a genuine conversation in terms of who is left behind, why are they left behind, and how do we bring them on board so that we are able to take on this responsibility as countries. And some of the examples is that, for example, we are still leaving behind children who are newly getting HIV infected. We have children who are not accessing treatment, even when we know we are talking about universal access to treatment. But we also know that, for example, in Africa, where I come from, adolescent girls and young women are still struggling with prevention. I know my friend Micho is going to talk about this, but it is unacceptable when we have all the tools in place that we are still talking about people not able to access prevention services. And therefore, the question is, are countries ready for that? is that what we mean when we talk about sustainability? Then how about key populations? I've already talked about this. If you have laws and policies and practices that are criminalizing certain groups of people, how are you going to take up that? So those are some of the things that they need to take into consideration. But also importantly, and one of the key issues that doesn't come up very well as we talk about sustainability is around inequality, not in terms of populations, not in terms of people, but in terms of countries. There has to be a genuine discussion and conversation between the haves and the have-nots, between the global north and the global south. What does the global north think about the global south in terms of access, in terms of equality, in terms of equity? There has to be that genuine conversation to the extent that when countries are being told to take up the responsibility, again, the global north and the international community must be aware that probably these countries and our countries are not refusing to take care of their people, but we are still limited in terms of resources, in terms of funding. And therefore, there has to be global solidarity that continues until when the countries are ready. Yes, the countries have to show cause and put domestic resources, but it is not, in my thinking and the community's perspective, it is not yet possible that our countries are going to take care of our lives, are going to take charge of the responsibility. And therefore, we have to set targets that are short-term, long-term, and medium. And therefore, sustainability in our thinking and what countries have to put into consideration is that it is a long-term process. And PEPFAR, for example, in their 2025, they have shown us how they are thinking around this, but it cannot be a 120, 2030 target. It has to be a long-term target. That if you have had people on treatment, for example, I'm 17 years on treatment, and now I'm being transitioned to I don't know where. So the question would be, there has to be a long-term plan that is going to enable people be transited to where they have to be transited for sustainability to happen. And lastly, but not least, there has to be a conversation and a genuine conversation around the health and community systems readiness. For example, we know we are doing a lot of work around community data through community-led monitoring, but how much of our data is being used? How much of it is being used in terms of informing policies and decisions, and at what level? How, for example, are we translating the UNAIDS global plan or strategy of community-led responses? Where are the communities in terms of leading the responses? So all those issues must be discussed so that at the end of the day, it is going to be the communities. When you talk about sustainability, it is the communities that are going to take up the burden and the response. But therefore, they must be prepared for the shock and they must be ready to take up the mantle so that at the end of the day, we don't slide back, but we are able to sustain the gains that have been made and accelerate to the next level. Thank you very much.
Thank you, Lillian, so much for the very clear and passionate call to action in terms of what's needed related to partnering with different countries in different stages of health financing, and also related to criminalization, stigma, and really what it takes to enable health for all people, and enable continued access to HIV services for all. So with that, I would like to turn to Dr. Thuy, who is works with the Ministry of Health as the Vice Head of Cabinet at the Vietnam Administration for HIV/AIDS Control, and who is a longstanding and really brilliant implementer, technical lead, and advocate for sustainable financing for HIV. So it's been my honor to work with Dr. Thuy for many years. And so Dr. Thuy, we'd love to hear more, to Lillian's point. There's a lot of time that is needed for countries to look at how to finance HIV prevention and treatment. And so Vietnam has a brilliant experience with financing HIV treatment, and as well right now is on the road to looking at ways to finance PrEP in particular. So it'd be wonderful for all of us to hear from you on, what has the experience been like in Vietnam? What are your key takeaways on the strategies that have been most successful for financing the HIV response? Over to you.
Many thanks, Kim, and good morning, good evening, everybody, and the organizer for giving me a chance to share with you what Vietnam has done so far for our initiative on sustaining HIV service recently. I will start with our experience with the transition from donor-based ART program to health insurance fund. You may know that we start our transition for ART program 10 years ago. At that time, Global Fund and PEPFAR contribute 70% of ARV drug in Vietnam. And for this transition, we have to advocate for the Prime Minister to issue a resolution which requests our province to secure a certain fund to support 100% of people living with AIDS on ART will be enrolled in the health insurance scheme. And with a very strong political commitment from central level to provincial level, our province in Vietnam has allocated a certain fund to buy health insurance card for people living with AIDS. And a lot of provinces, they launched different strong campaign for education and communication for people living with to buy health insurance card by themselves. So if in 2016, the enrollment rate is around 60%. It has been raised up to 96% this year. Only 4% left for the 10%, 100% target. And up to now, health insurance have been paid for 60% ARV drug in Vietnam. And the rest of 10% of people on ARV now belong to second regimen for like pediatric or some special groups still get support from Global Fund or state budget. So a lesson learned for Vietnam is the country lead for self-financing journey. How we can mobilize strong commitment from the center level to provincial level when we build up special mechanism for support for people living with AIDS. And stakeholder engagement is a very critical thing. We have to advocate for different layers of the government, like Ministry of Finance, MP, Ministry of Planning and Investment, and agency belong to the National Assembly. So some legislation we can get through from them. Turning point to PrEP, I learned it a lot from our workshop today is how we can find a better mechanism to support for prevention service. And for Vietnam, it really quite challenging for us for transition a PrEP program. I must say that it may be 10 times harder comparing with the ART program. And up to now, 100% of PrEP in Vietnam is still get funded from the PEPFAR and Global Fund. And with a great support of different holders, we now just reach only 25% of our target, comparing with 40% of our target in the National Strategy for HIV toward 2030. So now if the donor reduce their funding, how we can make up about the gap for the PrEP program. Up to now, based on our current HIV law and our other legal document, we could not advocate PrEP to cover by government fund. So now, with a very important strategy for HIV, we have to find alternative option. And I must say that with a great support from the past step project, Ministry of Health start working on a sustainable plan for PrEP, in which we explore how to expand commercial PrEP to work a cost-effective manner. And more important is how we continue to expand the PrEP coverage. We also initiative for private sector engagement for the PrEP program. When we have a different dialogue and technical working group at central level and also local level, we also provide technical assistance for local authority to diversify the market and the supply of the drug and also the HIV test agents, reagent for the PrEP program. I think that 2025 is really a challenging year when we continue advocate for the government coverage for PrEP, but we still have to keep increasing the coverage of PrEP to meet our ending aid toward 2030. And we do hope that the donor fund still, the PEPFAR and even Global Fund still be with us to help us to finalize the legislation to mobilize additional source, especially the mechanism to get more effective for private sector engagement and or social contracting. And by the time we also build up the evidence for the effectiveness of PrEP, so we continue the advocacy for the government for coverage from different sources. So that is Vietnamese the lesson for our practice. So I'm very happy to hear from you any question or clarification. Thank you, Kim.
Thank you so much, Thuy Anh. Really fantastic to hear both about the successes of Vietnam's experiences to date with expanding health insurance coverage and also some of the challenges that you're facing and how you're considering diversifying support for covering PrEP in the future. I'd like to turn now to Dr. Grace Namaganda, who's on the camera, yes. She is the project director for EPIC in Namibia and a senior human resources for health advisor with Open Development. Question for you, Dr. Namaganda. Open Development has been working with the government of Namibia to sustainably finance HIV services as part of the country's UHC and PHC reforms. Can you share a little bit more on those reforms happening in Namibia and specifically how the country is working to prime the broader health workforce to deliver high quality HIV and related services? I think you're on mute still, actually.
Sorry, thank you so much. Namibia, like many countries, is implementing many reforms to advance the UHC agenda. And in Namibia, sustaining HIV/AIDS, the gains made in combating HIV/AIDS is one of the priorities of a priority agenda in the UHC. So there are various reforms. We have recently, the government has revised the essential services package so that we can be more responsive to the population needs as they change. There's a lot of discussion around the community health strategy and the community health workforce, trying to professionalize that cadre and to see how to actually mainstream them into the government establishment. There's also an aspect of health financing reforms to make sure that we reduce inequities in terms of and ensure financial risk protection. Because in Namibia, there's a big divide between the people who can actually afford and those who can't afford. So as Open Development under the EPIC project, our mandate or role is really to make sure that as these reforms are ongoing, we are participating, but most importantly, to make sure that the government has the data they need to make the right decisions. We've also learned that having the data alone is not enough. So we are also trying to work with government to make sure the data is in the form that they can use and also support them to actually use the data to make the different decisions. So we've done a lot of things since we've been here 3 years. I think our starting point was really to help the government to know where they were. By the time we came in 2021, the government did not have any kind of information system. And it was not very clear how many health workers the government had, who they were, where they were. And so it was making it very difficult to actually plan. So we worked with the government and established the Human Resource Information System for Ministry of Health. And I think it's the only ministry now in Namibia which has an information system for HR. We also, of course, that only provides data for the public sector. So we needed data on mission facilities. They call them mission facilities, but what we call PNFPs. We also needed to know what was happening in the private sector and other areas. So annually, we actually work with the government to conduct HRH analysis and come up with what we are calling a health workforce status report. So the health workforce status report provides very comprehensive data on donor-supported health workers, where they are, who they are, the ones in mission facilities and others. So that was one of the biggest achievements. First of all, just establishing where we are, but then we needed to know where we needed to go. What is the need? With the revised essential services package, what were those HRH implications in terms of numbers of health workers needed and the type and where they would be required? So we conducted a very comprehensive workload analysis using the WISN methodology for all the professional cadres in the country and for all health facilities. And this information, of course, is being used for various things to inform the revision of the establishment so that the staff establishment or staffing norms are aligned to the population needs. It's informing deployment and recruitment and also training of health workers. But that is the work we've done in the health sector. We also realized, especially when we came to transition discussions and planning for sustainability, that there was a number of cadres, especially that are working under the DREAMS program, that are not mainstream under Ministry of Health. Instead, they are under Ministry of Gender, Ministry of Youth, Ministry of Education, and other ministries. So we started off by conducting a landscape analysis in terms of health workforce, but also services to identify opportunities for transition pathways. So based on that workload analysis, landscape analysis, we also followed it by a workload analysis for the social services workforce to identify what was actually needed to be able to sustain the epidemic. It was not about the services, but the epidemic. So it entailed identifying what are the critical services that are needed and which cadres would be most appropriate to provide these services. So we are actually currently working to introduce a new cadre called social auxiliary worker, because Namibia has a shortage of social workers, which is very unique to this country. So the Act provides for the establishment of a social auxiliary worker. So really what we are, right now we've finished all the analysis and we are pivoting to supporting use of this data. So use in aligning staff establishments in all the different ministries to the needs, establishing new cadres where it is required. And also for Ministry of Health, they have this big, very politically supported strategy called the Health System Strengthening Strategy, which is about 900 million worth. It has a lot of interventions for the health workforce. For example, they want to recruit, they want to train. So with this health workforce analysis results, we are able to guide on which cadres should be recruited, which cadres should be trained, and in terms of projections. And in terms of transition pathways, the analysis we conducted in both Ministry of Gender and Ministry of Health was able to actually map the roles of these people and then map what they're doing under donor supported and identifying an equivalent cadre on the government establishment and seeing what would it entail, what would it take in terms of transition. If we needed to transition these numbers, of course, the numbers to be transitions would be informed by the data that is obtained from the assessment. But if they were to be transitioned, which positions would they transition in? Of course, we've identified some gaps. For example, some of the donor-supported health workers do not have the minimum qualifications, so they would need bridging courses to be able to meet those qualifications.
Hi,
So
Grace,
there's a lot
thank
more. Yeah, thank you. That is it. Thank you.
I know there's a lot and there's so much detail in terms of what's required for sustaining health workforce, and even outside of those that report through the Ministry of Health. So thank you. Really excited reforms underway in Namibia. With that, really excited to hear from Mitchell Warren, Executive Director of AVAC. Mitchell, we've got some great HIV prevention tools that are now available. And the key question is what can we do to financially sustain them, particularly thinking about lenacapavir and CAP, but also oral PrEP, as you heard from Vietnam. So over to you for brilliant solutions. Thank you.
Well, I'm not sure I have brilliant solutions, but I'm delighted that much of what I think about these issues were covered beautifully by both Ashneil and Lillian. So let me just restate two things that I heard them say. And I hope I'm not misinterpreting or misrepresenting their views, and I'll take them as my own if they disagree. Picking up on something Ashneil said, I would argue, at least in the HIV space, but even in other therapeutic areas, prevention is the sustainability response. And I want to be really clear about that. I think sometimes we think, well, how, given the need for treatment, for vaccination, for care, all of which are critically important, we think, well, what's the kind of sustainability piece of prevention, or how do we embed prevention in sustainability? I believe prevention is the sustainability agenda. And certainly from the HIV perspective, with 1.3 million new infections every year, if you can't drive that down, as Ashneil described, we cannot sustain this effort, because we now have 40 million people in need of life-saving care, and that in and of itself is prevention. And if we're adding 1.3 million to that list every year, and the great news of the treatment being so good that people aren't dying in huge numbers in the way they did when many of us started our careers, that's not sustainable. So that's part one. PrEP in and of itself is not the answer, because I don't believe any therapeutic area has a single answer. But I do think there is innovation, certainly in the HIV space right now. But also, I think about planning for a TB vaccine, thinking about malaria vaccines rolling out. We have this huge opportunity, but we also have something Chris Elias, formerly of PATH, when he said this, he first told me this when he was the leader of PATH, now, of course, at the Gates Foundation, the risk of an innovation pileup. And I do think that that is the risk. We create all of these wonderful new tools, diagnostic, preventive, therapeutic, and if we can't deliver them, then we won't be able to sustain global health in any form or fashion. So we need to think really creatively if we're going to continue to develop these new tools, as I fervently believe we must. We have to make sure that we figure out how we can deliver them with speed, with scale, and with equity, so that we can actually drive incidence down. And I think lenacapavir and cabotegravir do provide a huge opportunity. It's going to be a test case. Can we step up? And it's at a time, as Ashneil said, we need to make bigger investments, new investments in these new technologies at a time when resources are shrinking. So we have to make trade-offs. And I think fundamentally this is part of the sustainability piece. And then finally, I just want to pick up on what Lillian said, because we can talk a lot about new tools, whether for HIV or for anything else. Products don't end epidemics. Vaccines didn't stop COVID. PrEP is not going to end HIV or AIDS or a pandemic, because of the fundamental issues. And Lillian's exactly right. If we don't address human rights, if we don't make sure that we take a person-centered approach to everything we do, then we will not only will we not reach our global health targets, but we absolutely won't sustain anything. And I think we all know that, but I do want to make sure that for all the enthusiasm of new technology, that we don't become so enamored of them that we think anything is a miracle drug. There are no miracle drugs for any therapeutic area. They are really exciting innovations. We have to deliver them, though, in a person-centered way that meets people where they are and addresses these huge systemic and structural issues. And again, it's not unique to HIV, but I think HIV shines such a bright light on these things. And I should just also say thank you to PATH and to everyone on the call to really bringing us together in this really important conversation. Timing is critical.
Great. Thank you so much, Mitchell. I haven't met you before, but I can hear the enthusiasm and passion in your remarks and your voice. So thank you for that reminder. I think we're going to hear we have time for one more panel question, and then we're going to try to bring back Dr. Johns and see if we can hear her presentation. So finally, we're going to turn on this panel to Martin Slavic, who is an associate partner with Open Capital Advisors Healthcare Practice, where he leads the design of innovative financing solutions to better direct interventions and funding for impact and catalyze sustainable private sector activity. So Martin, as countries are creatively thinking through how to finance their HIV responses at this point, including some of the approaches that have been highlighted by the speakers and panelists today, in your opinion, what other innovative financing mechanisms should countries be exploring at this point? Over to you.
Thank you so much, Laurel. Increasingly, sustainable financing and funding is very much becoming top of mind. For donors who want to ensure long-term sustainability for interventions, governments who want to more effectively utilize domestic resources with growing populations, and even for businesses, local businesses who need capital to grow. And while there is still a huge need for donor funding in the space through the likes of PEPFAR, Global Fund, and others, as well as domestic government expenditure, there's need to mobilize even more to bridge funding gaps and improve resourcing efficiencies. And that's where there's an opportunity to leverage innovative finance, both for public and private sector stakeholders. On the public side, figuring out how to use public funding from donors and domestic financing more effectively alongside greater co-investment, and even increasing coordination between ministries of health and finance in tandem with increased capacity building and knowledge sharing of what funding and financing mechanisms are available, which I'll get to. But on the private sector side, it's also figuring out how to scale businesses for development outcomes, as well as partnering with local governments to build supply chains for HIV commodities like diagnostic kits, ARVs, condoms, especially in more mixed-use health systems. And then really getting the public and private sector to kind of talk to each other, because I think what we found is the language is often disconnected and it affects partnership building. More broadly, there are a range of innovative finance tools and mechanisms that can be used. At an ecosystem level, there's things like pooled procurement mechanisms where buying commitments are aggregated together. There's debt swaps where countries convert debt obligations and repayments into investments for healthcare, which could include HIV targets. For example, the Global Fund has a debt to health debt swap mechanism. There's broader donor funds and facilities, which could include bilaterals and multilaterals, working with foundations and philanthropic organizations such as Gavi and the Global Fund to pool financial contributions and more systematically work towards driving government initiatives, but also working increasingly with development finance institutions to introduce concessional loans on top of the grants. For direct interventions, there's also risk-sharing mechanisms, things like community-based insurance schemes, behavior change mechanisms like incentive-based payments, and even challenge funds. UNAID ran a challenge fund a few years ago in Kenya to drive HIV self-testing that was pretty effective. There's also public and private partnerships. As Diana mentioned, developing partnership between local governments nationally and subnationally with local supply chain actors, such as manufacturers, warehousers, distributors, and even parastatals have been quite effective. And then finally, blended finance transactions at a direct level. So direct investments for private innovators, local businesses, but then also broader funding vehicles, for HIV commodity supply chain actors using grant and catalytic capital to grow their operations, crowd in additional investment from concessional and commercial sources, really for the purpose to decrease the burden on the health system. By no means is all that exhaustive, but hopefully it gives you a quick snapshot into the different tools and mechanisms that are available. But thank you, and back to you.
Thanks, Martin, and thanks to our brilliant panelists. You brought out such critical aspects of the many dimensions that we have to consider related to sustainable HIV financing. I know as Lillian underscored, this is going to be something that's done in partnership with countries and is based on the real state of financing in each country, and really ensuring that HIV financing ensures access to sustainable HIV services for all people in all places.
I think we are just coming to the end now of this session. I appreciate that all of you participants were able to remain on the line a bit longer. I'm going to try to just sum up some of the themes that I heard. It's a bit of a challenging task given the range of topics that we covered and that the richness of this discussion. But I first just wanted to thank all of our illustrious speakers today, from the governments of the United States, of Kenya, of Vietnam, also hearing from the experience of Namibia, from global development partners, civil society advocates, and NGOs and consulting sector. Thank you so much for your time and your insights. It was this is really fitting way to commemorate World AIDS Day, especially as we're drawing nearer to the 2030 deadlines. So some of the themes, I'm just going to try to bucket them together a little bit that I heard today. First, that Ashneil, you mentioned that we've experienced tremendous progress, but that's not the same as victory. There's still work to be done. And in this era of constrained global financing and some significant political uncertainty, that we really must all pull together to draw closer to these 2030 goals. That efforts to sustain the HIV response must be considered as part of holistic, comprehensive efforts to achieve universal health coverage, and they must be aligned with country UHC financing and reform efforts. We really cannot afford the need to address these deeper systems barriers that are impeding epidemic control. And that really means integrating HIV services into broader public health packages, as we just heard from Dr. Tracey, the experience in Kenya. Another theme was the importance of working through domestic systems, including domestic financing systems, as much as possible, that this is really key. This is the key to sustainability, this kind of focus on alignment, aligning external funders' investments with strong domestic processes for identifying local priorities and supporting evidence-informed resource allocation aligned to those local priorities. Dr. Koonin's remarks, he emphasized again, and so I think several others did as well, the importance of moving towards the Lusaka agenda priorities, that we have joint approaches, coordination, strategic and operational coherence in our investments, one plan, one budget, one M&E system cannot be reiterated too much. We also heard, though, about bringing in new actors and new funders, continuing to engage the insights and innovations and energy of the private sector to expand coverage and reach key populations. Martin spoke a bit about some of those innovative financing mechanisms that we need to continue to explore and to tap. We heard about coordination and defragmentation, the importance of pooling our resources, simplifying the funding arrangements, defragmenting even M&E reporting systems and reconnecting across sectors. We heard a bit about Vietnam's great success in bringing comprehensive HIV services under health insurance coverage and some of the challenges as they're moving towards expanding coverage of PrEP. Diana shared a bit with us about the importance of workforce, keeping that front of mind as we're thinking about integration of HIV into primary healthcare systems. And Grace from Namibia also spoke to the importance of the data systems for that health workforce planning processes, the importance of data analysis for planning the future workforce, especially in the context of expanding to new cadres of workers. And then a couple of final points. We heard Mitchell's great call to action and reminder that sustainability is prevention. And at the same time, his caution that products don't end epidemics, that systems change and human rights are really fundamental. And maybe the final thing I'll say is the overarching theme that I come away with from all of this is that sustainable financing is inherently political, and that inherently also means that we need to continue to push to bring all voices to the table to determine how financing will be raised, how it will be allocated, how it will be used effectively and equitably to reach all of the communities in needs. And I think Lillian, you really you brought this out in reminding us to hear the voices of the 555, not just the 95, 95, 95. So that was a great reminder as well. So I hope all of you have learned something today and that we're able to continue these thought-provoking dialogues in each of our own contexts and organizations. Thank you for staying on a bit longer and staying with us to listen. And thanks again to our panelists. I hope everyone has a wonderful remainder of your day. Thank you so much.
Thank you. Cheers, everybody.
Thank you.
Thank you. Bye.
Thank you.